Hello, and welcome back to another episode of Creedle. I mentioned a few episodes ago that I was going to have a palliative care doctor on the podcast, hopefully soon, and that moment has arrived. So I'm joined today by my friend, Dr. Ethan Schimmoeller. He's a hospice and palliative medicine fellow physician at Ohio Health in Columbus, Ohio, where he resides with his wife and two children. He received his medical degree from the University of Cincinnati College of Medicine and an MA, Master of Arts in Bioethics from the Ohio State University. And as we're recording this, we don't yet know the outcome of the Ohio State-Texas game in the college football playoff semifinal. By the time I release this, we'll know who won, so we'll see. He completed his residency with Memorial Family Medicine residency in South Bend, Indiana, which is how I met Ethan and his family, where he served as academic chief resident and was awarded Resident Teacher of the Year. In his clinical practice as a palliative care physician, he sees patients with serious illness and those who are dying, and in his academic work, he writes and teaches on the moral and spiritual dimensions to medical practice. Ethan, welcome to the show.
Great to be here, Zach.
Yeah, I'm excited to have you. I think that palliative care is obviously very important because it is the part of medicine that many of us at the end of our lives will encounter and will hopefully assist our transition into death. But it's one that we don't know about for a couple of different reasons, I suspect, and I'd love to hear your perspective on this. But I was paying attention to a lot of the debate around assisted suicide in the UK. We've had a good amount of discussion of it in Canada as well, but we just had this passage of a bill for assisted suicide at second reading in the Houses of Parliament in the UK. I did a solo episode on this a bit ago. And I was noticing a lot of discussion around palliative care, and specifically a big deficit of knowledge about palliative care. People don't know what palliative care entails, what it can and what it cannot do. And I consider myself one of those people. I don't know a ton about palliative care. And so I thought we could hop on a show and talk about that so that we can have a more informed understanding of what this is, the importance of palliative care, how it should impact our discussions of assisted suicide. And then, I've always wrestled with a few different scenarios for end-of-life care. Maybe we could talk through some of those if we get to it. So that's my vision for today. Let's start with something very simple. What is palliative care?
So it's understandable that there's confusion about palliative care. The term itself has an ambiguity packaged right within it. A pall or a pallium is something that covers. It's a shield. We know this liturgically. It conceals something that is holy to protect it, so to speak. But it also can conceal other things that maybe we ought to have our eyes looked upon. So it's kind of an ambiguous term in and of itself. So I understand why there's a lot of confusion. I'll say I confront this every day in my clinical work. I'm constantly explaining to patients as well as to folks around the healthcare system what it is. So palliative care is medical care in conjunction with medical care for serious illness, in conjunction with specialist care that is devoted to lightening the burdens of illness. Today, there's a much more precise definition than what perhaps there was decades ago or centuries ago for this. It's for folks with serious illness. It's to lighten the burdens of their illness from any stage in their illness trajectory. Let's imagine you're diagnosed with an advanced lung cancer, for instance. At moment of diagnosis, you might have years to live. That is a time where frequently we as palliative care will get involved. There's a lot for us to do because at that point, folks might have considerable symptoms developing already. They might have some decisions to make. Probably not too many. It might be pretty straightforward. Just follow the medical standard of care, so to speak. But with an eye towards thinking about the future and thinking about what does this mean for my life? How does this disrupt the narrative of my life? And how am I forced to re-narrate my life going forward now that I have this new reality of illness? That's palliative care, broadly speaking. It's responding to serious illness. That's how I would think of it. And it's in parallel to the rest of medicine, the rest of medical care, intensive life-prolonging measures like chemotherapy for your cancer, surgeries, ICU sort of care with ventilators and such. It's in conjunction with those things. I say that to say that hospice care is a little bit different. We share a lot palliative and hospice care. Today, hospice care is for folks who our medical best estimation of prognosis is less than 6 months. So it's end of life care that is directed towards comfort, which is to say it's directed towards doing the things that matter most, not spending whatever time God has left for you in the hospital, getting poked and prodded, etc. Doing the things that matter most and feeling as well as you can while you do it to help capacitate you for that. So that is palliative care and hospice very briefly today. I'll say that, again, those are rather precise definitions, which is one reason for confusion today. That has not always exactly been the case. So, what we now call palliative or hospice care, it's been around forever, quite frankly. In medicine, we tend to think of this as a new thing, and it's new in as much as it has been institutionalized and been accepted and embraced, although sometimes uncomfortably, often uncomfortably so, by the general healthcare system. Really, the foundations for what we do have been around, as long as there's been physicians. Most of medicine before the 1950s was palliative in nature.
Right. I was going to say that's probably the case. Yeah. It's only recently that we have sort of dermatologists and all these sort of more cosmetically oriented practices or the specialties that can do advanced treatment of advanced diseases. Now we can do those sorts of things. Back then, you mostly were either probably managing the common cold or sort of managing someone's death because they had a cancer that we didn't know how to treat or something like that.
Yeah, medicine was not directed towards curing disease. It was directed towards
symptom management.
Making it as easy as possible to endure.
Because before we had a germ theory of medicine or any idea of the microscopic world, we didn't even understand how you could actually cure diseases. So it makes sense that it was mostly about symptom management. How to make someone feel better.
Yes. Don't get me wrong. The practitioners of humoral theory, from Galen onwards, they definitely truly believed that they were making people better in body, and they perhaps were at sometimes. Bloodletting is pretty effective for hemochromatosis, for example.
Wait, what's hemochromatosis? What is that?
A condition of iron overload.
Okay. So you let the excess iron out by literally
bloodletting
bleeding.
is still the treatment of choice for hemochromatosis.
Really? Wow.
Yes, they just don't call it that. They call it.
How do you get iron overload? Is that a genetic thing or is iron poisoning?
The two ways. Historically, genetically, it's not uncommon actually.
Okay.
Actually, members of my family have a single gene copy. You need two for clinical illness to develop. But with modern medicine, it's iatrogenic. It's a side effect of our therapies from people who get repeated blood transfusions.
Got it. Okay.
Yeah.
And then they've got to get a blood untransfusion to let the extra iron out.
Yes, there are more. How do I say this? Elegant means of treating that.
It's no longer just dangle your arm off the side of the hospital bed and cut it open.
Correct. But all I have to say this is an immense gloss on philosophy of medicine, ancient versus modern.
Yeah.
Humoral theory versus what we now know as modern technomedicine. The old practitioners, they didn't have any sense of curing illness in the way that we do today. They didn't think in those terms.
Yeah.
They really did not think in those terms at all. They thought much more in organic terms about, restoring harmony of the body, which was itself a harmony with the spirit, which itself was a harmony of the, unseen celestial realms, which itself was a harmony of the inner life of God.
It totally makes sense. Yeah, we should maybe go back to that idea because I think it will connect with some of these things that we talk about with respect to end of life care. Something you said though about the modern sort of techno view of medicine made me wonder if we've lost something there. Not that we should go back to bloodletting, obviously, or go back to the humoral theory of medicine, but I wonder if in a shift from symptom management to cure, if we have potentially overswung that pendulum and now are so focused on cure that we've lost sight of this natural arc of human life, the fact that we are all dust and to dust we shall return. And so we get into this pattern. I've seen this happen with elderly people in my family and in my wife's family, we just get into this pattern. It's like, well, let's just kind of give him one more pill. Let's give him one more therapy. And at the end of someone's life now in America, it's not terribly uncommon in my experience for you to be on 20 different pills a day and going to see doctors 4 of the 5 days a week that you can, and in and out of the hospital. And we're just treat, cure, with no acknowledgement really that this person's life will come to an end sooner rather than later. And it seems like maybe palliative medicine, hospice medicine practiced well is an acknowledgement of that fact that we are not the masters of our own fate as much as we would like to think we can be. Our lives will come to an end. How do we end? How do we die well?
There's a lot to unpack there, for sure. The technomedicine that all of us think of that's been around since the 70s, you could say, ever since at least the advent of organ transplantation or the ventilator, our ability to keep people alive artificially has been yoked to a metaphysical change, you could say. It's yoked in with all of the, the characteristic thought forms that define modernity itself. It's yoked in with positivism, it's yoked in with materialism, etc. In a way, I think, here's how I think of it. We have become tacit transhumanists. We maybe we don't think much about where our commitments lead and how we experience illness and how we relate and use with medical technology, but that ultimately is where technomedicine leads to, is to transhumanism. It's a desire to make a sort of quasi-religion out of technology. And, historical tidbit of why palliative care as we now know it even exists. I mean, it's more than a tidbit. That is exactly why it exists. So modern technomedicine grew up, as I said, 50s to 70s in that era. Coextensive with that was physicians forgetting about suffering and dying patients. That was a big deal. Nobody in medicine wanted to admit it seems like. And it gave birth to phenomena like the patients' rights movement in the 70s, led to a number of Supreme Court cases and the birth of bioethics and, the use of new sort of biomedical terms like autonomy to try to, use the patient's autonomy to push back against the physician's paternalism that's trying to force treatment on me. That's trying to force, medical technology on me without getting my consent first. Born up with that was the birth of modern hospice care. A critical figure in this is a Brit, Dame Cicely Saunders. She, fascinating life story. So professionally, she was, she was a volunteer in a hospice first, and then she became a nurse, and then a social worker, and then a physician, actually. She also served in World War II, I believe as a nurse at that point, to wounded British military members. And she saw how much suffering and dying patients were effectively abandoned by doctors. And there were pain medicines available. Pain medicines have been around for a long time, but doctors just didn't want to use them for complicated reasons. The knowledge was there to know how to use them. They just chose not to use them and effectively abandoned people. So she saw that as a major problem and really gave birth to the modern hospice movement. Her religious background is noteworthy, I would say. So she, in her younger years, was an Anglican, sounds like kind of an Anglo-Catholic. You would know more of these finer distinctions than I would. At times actually attend Catholic services, other times Anglican services. Had a relatively traditional kind of view. That was around the time that she was a volunteer in a hospice. And this was, I believe it was the Sisters of Charity ran this hospice in Britain that she volunteered in. And that's where she learned how to do hospice. At least that's where she learned the religious foundations of care and compassion for people who are suffering and dying.
Amazing.
She learned it there. She learned it from I believe it was the Irish Sisters of Charity is who she learned it from.
Did she remain in that sort of Anglo-Catholic world, or did she
that
come away from that? Unclear.
She remained Anglican, but she became much more evangelical.
Okay.
With time, and the more time went along, from my gloss on her biography, is she got more and more kind of mainline Protestant sounding.
Okay.
Much more open to not just ecumenism, but to interreligious stuff.
Okay.
Her views on spirituality became seemingly more informed by someone like Viktor Frankl than by the gospel. I'll put it that strictly.
Okay. But do you think it's fair to say that her commitment to end-of-life care was primarily motivated by her metaphysical commitments, even if
Absolutely.
they were...
100%. And that's... So, I said that pre-modern medicine was palliative in nature.
Yeah.
And hospice is a very old thing. Hospice is not this new thing. Its forms are new, but the idea is very old. You think back to the ancient Roman Empire in the early days of Christianity, particularly surrounding St. Basil the Great. He organized some of the beginnings of the first hospitals. He wasn't the first one, but he was one of the first organizers as a bishop of his see to organize those. And there's some profound accounts about the impact that lay Christians, a few physicians, but mostly just lay Christians, caring for the sick and for the poor. The distinctions weren't near as crisp as what we have them today between the sick and the poor. They're often the sick poor who didn't have anyone to care for them. But that was the beginning of the church institutionalizing the virtue of hospitality, taking in the poor and the sick, feeding them, clothing them, caring for them. And it was things like that were perpetuated in, the Benedictine monastic tradition. Their hospitality continued this medical bend on it, where they provided a little bit of medical care, but it was mostly compassion for the sick poor. And that tradition remained essentially intact all the way up through the Irish Sisters of Charity that Cicely Saunders encountered. What she described was very close to what was true centuries prior.
So how was it that you became interested in this field of medicine? I mean, I've many friends who are doctors, and I've been friends with most of them since before they started med school. And there are so many options available to you. And I think maybe without fail, no one doctor who I know has gone into medical school wanting to be the type of doctor that they come out at the end, because you're just exposed to a whole world of this. So did you know going in that you wanted to be a palliative care doc, or was this something that you just discovered and sort of fell in love with along the way?
I had a sense that it would end up being right for me. I had the good fortune as an undergrad to meet two different, very seasoned and faithful Christian hospice and palliative doctors that were deeply influential on me. They impressed me. They imprinted on me the religious and spiritual mission that comes with attending to people who are suffering and dying. And I certainly entered medical school with some of that, and had it all the way along. With that in mind, well, I also had the good fortune of spending a few weeks at Mother Teresa's Home for the Dying in Calcutta.
Oh, I didn't know that. Wow.
Yeah, I spent 3 weeks there before I started medical school.
Oh my goodness.
In the summer between college and med school.
Okay, yeah, let's pause and dive into that a little bit. Okay, so first of all, what is this Home for the Dying? Is this one of the ones that she started? I mean, because her whole ministry was around caring for the sick and poor and the dying in the streets, right?
Yeah, this was the first home that she started in Calcutta.
Amazing.
If you've seen photos of John Paul II visiting one of her homes with her, this was it. Wow. This was the one. So
give us an idea of scope here. How big is this building? How many people are in here at one time? How many beds?
It's not that big of a building. And the bed count works very differently than how we do it here today.
Sure.
I mean, this is much more military bunking style.
Is it actually bunk beds?
That's not bunking, but
okay.
As opposed to private patients,
like the World War II
televisions and
hospitals where there's just like little beds next to each other, all in a line in one.
Yeah,
room,
much
right?
more like that. Much more a military model is how we could think about it today. There were probably 100 people.
Wow.
Yeah, they had the men and women separated, and the sisters cared for them. They offered basically I mean, there was nothing fancy that they offered. They gave some medications. I mean, I didn't have much medical knowledge or background at the time that I was there, and most of them didn't speak English, so
Okay.
I wasn't able to talk to them too much on that front. But they offered care out of the heart of the gospel. Mother Teresa, a couple notable quotes on her mission with the Missionaries of Charity is that they are contemplatives in the heart of the world. They're not social workers.
Right.
They're not social workers. What they do is they bring the love of God to people who need it most. That's their mission, not social work. And yeah, it was wonderful experience to get to see that up close and personal and see the really dirty work that they do. They are not afraid to get their hands dirty. And yeah, it's certainly born out from their experience of prayer that is the foundation. A journalist once said, Mother Teresa, you could accomplish so much more in a day if you prayed less. And she was a busy woman, as you might imagine. She only slept 4 or 5 hours a night, and she would have a holy 2 hours in the morning before going about her day. And she said, no. That's when I need to pray more, the more that I have to do. That's our mission. And I did that with some intentionality to have that in mind as I was going about medical school, because I felt like I was entering medical school with at least some amount of eyes wide open, that I was going to be disappointed with what I saw on various fronts. And so I wanted to have some sort of a light post, a lighthouse to navigate me throughout that.
Yeah. What was your experience, or maybe even was your understanding of the sisters? It seems to me that there's maybe two ways that can go. When I think about doing that, going and serving the poor, the poorest of the poor in the slums of Calcutta, I would like to think that I would get in there and I would be serving them, and I would just have this overwhelming encounter with the love of God, and would just feel that motivating my core, my deepest part of myself. I think the more likely scenario would be that it would almost just it would hurt a lot, and it would be really, really hard, and it would be really, really gut-wrenching, and there might be some little moments of satisfaction or grace here and there, but I think it would really be a fruit of many years of reflection, where I would look back on that and realize the depth of what was happening there. What was your impression there? Was it more of the former, more of the latter, or something entirely different?
Oh yeah, my experience was much more of the latter.
Okay.
Oh yeah, this is yeah. I don't think you can go there and just have this. It's almost almost a kind of cultural colonialism.
Yeah.
With this, hey, I'm gonna do all this good. It was very humbling for me. I mean, I think I expected that to some extent. I expected to have my eyes open while I was there, but it certainly did happen. I was much more. I had many experiences of growing frustrated as a caregiver.
For sure.
And these kind of tough experiences had deep resonances in my soul, for sure, that were deeply formative going further.
Did it make you at any point question your path of medicine, or did it cement in you that desire to do that? Or both at various points?
Both is probably the best answer.
Yeah.
Yeah. I'll be completely honest. At every step along the training journey, and there are quite a few steps along the training journey.
There are, especially if you do what you've done with a residency and then fellowship and all that. So, yeah.
I've questioned it every step as I go. Quite frankly, when people ask me, and this is a really fun question to ask, what would be your alternative career choice?
Yeah,
I say, I guess probably the priesthood. So. If you can find a niche in medicine that is the closest to the priesthood, it's probably hospice and palliative care.
That's a really good point. Yeah. Yeah, I like that. Okay. Well, let's talk more about the sort of the techniques of palliative care, the how-to, and what we can and can't do. Because I was reading up on a lot of these debates around the UK assisted suicide bill, and the arguments that I'm about to bring up have bearing in Canada and anywhere that assisted suicide is legal in the US, and it's getting more and more legalized across Europe. So these are becoming very relevant. And to me, I don't think it's personally compelling, But the most successful argument that I've seen for assisted suicide is not actually about patient autonomy, although that's compelling to certain people. But I think it's really about compassion. And the argument goes like this. There are many people, tens of thousands, hundreds of thousands, millions of people around the world, perhaps, who are in agony as they die. And they're in such agony that they see death as a welcome release from that agony. And the only thing we can do to release them from their pain is to help them to die. I say that's compelling to a lot of people. And I can see the logic of it. You and I have metaphysical commitments that preclude assisted suicide as a virtuous possibility. But if you lack those metaphysical commitments, I think you're likely to be compelled by the compassion argument. I think of this guy named Coleman Hughes, who's a scholar who writes on actually a whole bunch of things, but he's been very prominent in writing on race relations and sort of the sociology of race in the United States recently. But his mother passed away from cancer. And I read his article on this recently in the Free Press. My mother passed away from cancer several years ago as well. And so we have some common experiences there, but he's been very supportive of assisted suicide legislation, or, assisted dying, death with dignity, whatever you want to call it. It's about assisted suicide. It's about helping people to end their lives. He's been very supportive of this, especially in the UK. He's American, but he thinks that's a model that should be replicated in the US. And he makes the same compassion argument that basically, for people who are really struggling, this is the compassionate option. Now, to my mind, there are a couple of presuppositions that are baked into that, Ethan. And one of those is it actually true that the only thing we can do for these people who are dying is kill them or help them kill themselves? And Twitter is whatever Twitter is, and I don't know who's behind the check mark that I'm reading on Twitter. But it was interesting because I was seeing multiple voices on Twitter say basically, I'm a palliative care doctor, I'm a palliative care nurse, whatever. This is an exceptionally rare case that someone is meeting the conditions that you describe, where they're in total agony and we really can't do anything for them. So maybe we can start there, Ethan. What are the facts on the ground here? How often is this the case? Are there millions of people around the world who meet these criteria that we have no other way of helping them other than helping them end it all?
Yeah. That sort of compassion argument is not based in facts. It's based in, it's an emotive argument to play into people's fears.
Yeah.
And there's a lot of other things to unpack with those statements, as you suggested. Yeah. The clinical reality, I would concur. That's not the case. There are not just scores of people dying in extreme agony because they lack access to assisted suicide or whatever euphemism you want to apply to it. That's just not the case. Perhaps in places where there's no access to medicine whatsoever, that would be more conceivable, but then they have access to nothing. So you're going to go there and try to kill them.
It is really, for those instances, it's like, okay, so you're suggesting that we just bring in the death doctors before we actually bring in palliative care doctors? Because that seems like a very backwards positioning of priorities.
Yeah. Yeah. No, the clinical reality is that we can relieve pain. The right to die movement really thrives on exception cases, as you pointed out. A very famous academic article that was written by Timothy Quill, and he's published in a couple different formats. He was one of the main plaintiffs in the 90s in the Supreme Court's rejection of assisted suicide in the United States, Baco versus Quill, after he ended the life of a patient that he called Diane and published it anonymously first, and then later came out and said that he's the one that published it.
Wow.
In the New England Journal of Medicine, which is perhaps the top medical journal in the world.
Was he prosecuted for that?
I don't believe he was ultimately prosecuted for it.
Okay. Wow. Well, because it was seen as compassionate, right? So who would, yeah.
Yeah. Well, there's a lot of attorney generals that would be happy to prosecute.
Yeah.
But
maybe not his state general at the time, whoever the AG was.
His in this, I think he was in New York State. But so the clinical question about pain control at the end of life is, we have the tools to control pain. There's a separate plane in which we can talk about pain, of course, but just talking about clinically, we have the tools to control pain. Yes, there are times where that can come a little bit at the price of consciousness. The lowering of consciousness is a well-described side effect of strong pain medicines, of opioids.
Yeah, I mean, like anyone who's, had their wisdom teeth taken out or something, and they go on, I don't know, Valium or Vicodin, whatever be used for that. I think I was prescribed one of the V's when I had my wisdom teeth taken out, and like, yeah, makes you a little bit drowsy.
Yeah. Now, in those exceptional cases where we're unable to control pain, this is more ethically hazardous, but shouldn't be dismissed totally out of hand. And that's a practice known as palliative sedation. Now, we could talk way too long about that topic. That's a whole nother issue than assisted suicide. But there are ways to, even for folks that are in the absolute extreme cases, and we're talking about fractions of a single % of patients here.
Yep.
There are defensible ways that one could, if you're not able to relieve their pain, at least lower their level of consciousness proportionately to ease their suffering.
Are we talking about like full on inducing a coma potentially for the extreme cases?
No, you have to think of sedation on a scale from fully awake to fully like operating room level asleep.
Okay.
There's the whole spectrum in between. So the most defensible way to do it clinically would be to lower it the minimal amount possible that the suffering is tolerable.
Yep. Makes sense.
I'll put it that way. And when it's done in the right situation, this is almost always very close to the end of life. When you've had the appropriate preparatory conversations, it does not shorten life either. It doesn't hasten death. That's critical, ethically speaking.
Yep.
So you put all that together, and I have very little patience for that sort of compassion argument. I think it's very interesting to try to unpack a little bit, not just suffering, but what this one physician, I'm forgetting her name. She published a famous article in the New England Journal many years ago about existential suffering. That's what she said was really at the heart of the right to die movement. And I think that that's what statements like that really play off of.
And she was criticizing the movement, or she was endorsing the movement?
She was endorsing the movement.
Yeah, okay. I mean, I think I agree with her, right?
Yeah.
I think I agree with...
I agree with her assessment wholheartedly. I couldn't disagree more about what to do about it.
Right. Yeah. No, that is fascinating. Like these people, I feel, at a loss for their very existence in the world. They are placeless in it. They are devoid of purpose and meaning. Therefore, we should kill them. Or help them kill. I'm being, a little bit like crass to drive home the point, but we should help them kill themselves. Is basically what she's saying.
Yeah.
And you and I agree with the first part of that, but this is exactly why we should not help them kill themselves. We come to diametrically opposed conclusions there.
Yeah. There's a way that the arguments based on autonomy and based on compassion get kind of interwoven here. It's interesting to observe that autonomy gets used in that circumstance as a way to inscribe meaning, add extra to what is a meaningless event of death. So by me controlling it, by me imposing my will upon it, I am imposing some sort of meaning upon it.
And you're giving it dignity, right? Which is why it's dying with dignity. Yeah, you're exercising your autonomy.
Precisely. That's exactly the sort of thing that all of that language plays upon.
Yeah.
And it's funny that language is not particularly new either, even though we now see it in the Right to Die movement. That is remarkably similar language that Friedrich Nietzsche used.
Interesting. Where did he use that?
In several different parts of his corpus. I know it's in Twilight of Idols, for instance. He's got this whole philosophy that, God is dead, we killed him.
Right.
Death and the fear of death and everything that's bound up with death preys upon our belief in God, he says, and not just like our religious belief, but the whole metaphysical structure around that. So one of the ways that we extend the death of God and bring it to its logical conclusions and move from passive nihilism to active nihilism, from a passive state of meaningless suffering into an active state of at least I can inscribe meaning upon my death and go out in the way that I want to, is by killing ourselves. That kills God. That is one of
Yeah.
Nietzsche's arguments, and it is perverted. However, it does follow from his presuppositions.
Yeah, I mean, this is like so much of Nietzsche, right? It's dangerous precisely because he gets so much correct. I mean, assisted suicide is, the final act of rebellion.
Yeah.
Yeah. So it is this radical assertion of the will that cannot be reversed, right?
Yeah.
By at least our own will.
G.K. Chesterton has this great quote that suicide murders the world.
Yeah.
It doesn't just murder a person; it murders the world.
Yeah.
And that's why it's a metaphysical offense, and why the church has historically treated suicide as such a grievous sin.
Right.
Not only, and as well as for the consequences for the person.
Mm-hmm. Precisely.
We pray for God's mercy.
Right. Yeah, I mean, that it bears repeating that the church has not dogmatically defined that someone who commits suicide is outside the reach of God's mercy by any means. No one is outside the reach of God's mercy. So we always pray for their soul. But yeah, I mean, it is. Nietzsche's right. It's such a final and definitive act of rebellion. And so, we cannot kill God, but we can certainly rebel against him to a total degree, which is exactly what suicide does. I think it's sad that we've gotten to a point in society where we can talk about suicide and describe it with terms like autonomy and compassion and dignity, because it may be the result of an act of autonomy, but it's obviously an abuse of the responsibility that should be commensurate with autonomy. It is the opposite of compassion. It is the antithesis of dignity. And it's crazy to me that we've arrived at this point where, left is right, up is down. We're radically confused on all of this. And I can be attacked by someone like Coleman Hughes, who I respect and admire on a whole host of issues, but, I can be attacked by him as someone who is devoid of compassion or charity because I don't want people to kill themselves. That's wild to me. That's wild.
Yeah. It reminds me of Alasdair MacIntyre, perhaps his most famous chapter that he wrote, chapter 2 from After Virtue. Mm-hmm. I believe that's a chapter where he talks about, we have all these pieces from a shipwreck.
Yeah.
And we're trying to put it back together, but we have no idea how it went together.
Right.
Like we have all these pieces, autonomy, compassion,
dignity. Yeah.
Right. Well, and we're just like, people are just throwing it together in this, this syncretic kind of way.
We think we figured it out. Yeah, we did not figure it out.
That's totally lost the context in which it came from.
Right,
so it produces an entirely different meaning.
That's exactly right. I mean, I think also I don't know if you've yet read the Dominion, The History of Christianity by Tom Holland. It's worth your time. I have, a few criticisms of it, but overall it's very much worth your time. It's a good book. But his whole through line is that Christianity has defined the Western world. And even today's woke movements use Christian language to advocate for their causes. So he talks about, in particular, LGBTQ issues and how they talk about autonomy and equality and dignity, all of these terms that are taken straight from the language of Christian civilization. And yeah, we obviously often misplaced, just as is the case here. So
yeah. Well, to reference the ancient hospice movement again, amongst early physicians, one of the practical reasons that the faith spread throughout the Roman Empire was the care and compassion that they offered to people. There was such a, ancient Roman culture. There was such just casual cruelty. We all think of the tigers eating people and the gladiators and, the martyrs. But there was a whole score of other casual cruelties, exposing your infants, for instance,
right,
among, many others that the Christians rejected very firmly. And not only rejected, but, went out and scooped up infants out of trash heaps, for instance.
Amazing.
And raised them. That was the early Christian testimony. And that's the kind of spirit that belongs in Christian hospice, if you ask me. This might speed up a little bit more towards today. what a truly Christian hospice would or should entail is, I mean, it's a whole nother metaphysic. Let's put it that way. A whole nother metaphysic than what the world is founded upon. A whole different set of.
Yeah. Well, let's peel that back a little bit, because I think it's worth exploring. So the technocratic view of medicine that you've already talked about, and this one that is grounded in a modernist, materialist, positivist commitment. One that is, I wouldn't even say a positivist metaphysic. It's really just, it's a non-metaphysic. It's a denial of the supernatural. It's a denial of anything that's not materialist. Maybe we could talk about modern psychology as having some sort of metaphysical commitment, but I think in most cases, there's just a sort of material theory of mind that governs most psychology today. So that practice of medicine is governed by these very materialist assumptions. Those assumptions say, here is all that there is. There is no transcendence. There is no eternal life. The Catholic metaphysic, and there are other faiths that share at least aspects of this, but talk about transcendence, talk about a common destiny of man, talk about a teleological nature, that we are made for eternal life, that we are unions of body and soul, not simply bodies and minds that are pure atoms, and that the soul is the eternal principle of man, but also, and this is unique to Christianity, that the body will be resurrected. So given those two, maybe I missed something there, so feel free to kind of fill in any blanks or fill in any missing pieces on either of those metaphysics. But given those commitments, how does that change the practice of palliative care? If you're a doc who has this sort of materialist positive orientation, how do you practice palliative care differently from someone who has a Christian Catholic metaphysic?
Yeah. Well, one first comment I'll make is about, palliative care broadly.
Yeah.
I suppose you might say secular palliative care, which oftentimes is in the neutral sense of secular, meaning just in the world.
Yep.
Not quite as secularist as the rest of medicine. It's much more open to religious experience and expression. Perhaps
is that generally, just real quick, is that openness because the palliative care practitioners are themselves open to like various metaphysical schemes, or is it because they recognize that this is like psychologically helpful for the practitioner to be like, yeah, you should do your prayers and do your yogic stretches and whatever the case is?
I think it's both and.
Okay,
that's the speculation.
Yeah,
I think it's both and. Although I said sometimes too open to religious experience. Open to experience for its own sake without discernment, which is to say without actually being rooted within a tradition within which to have religious experience, to understand.
So what's an example of that? Like you're not seeing practitioners like encourage people to go on ayahuasca retreats, are you? Like what's an example of the too open to experience?
No, that's exactly what I'm talking about.
Really? Okay.
That's exactly what I'm talking about. No, psychedelics, just like other niches of culture, are making a splash in palliative care.
Fascinating.
Yeah, it makes a lot of sense.
It does.
It's kind of funny, that sort of thing. I'll kind of package that along with all of the complementary and alternative sort of medicine things, acupuncture, yoga, mindfulness. On a philosophical angle, I give 2 thumbs up for striving beyond the merely physical toward something that is more ancient and holistic, etc. But on a theological level, no.
Yeah, this is sort of like an A for effort, D- for execution sort of situation.
Yeah. It's almost a sort of Gnostic syncretic thing, but that we're getting a little bit off topic. We're talking about palliative care in general has this kind of openness towards religious and spiritual experience. And I would say at its best, it's agnostic. It says this is important to people.
Yeah.
And we need to support them in the traditions that they live, that they inhabit, and that form how they understand suffering and how they understand death. That's kind of an uncomfortable position to be in. I will fully admit that's kind of the position of liberalism, I suppose you could say, trying to maintain some sort of metaphysical neutrality on these things and just kind of live in this middle zone. That is certainly distinct from what I would describe as Christian hospice. I mean, Christian hospice it's the ancient vision. You might perhaps just update it with the gifts that God has given us in modern medicine. I think that it would be, the modern pharmacology that we have access to, being utilized within a Christian context, within a Eucharistic context, you could say, so that, that teleologically directs what you do.
Right.
And that flows down to inform historically how Catholics have done ethics generally and medical ethics more specifically, and how they've approached death. For instance, one principle that is quite clear is at all times in life, but especially at the end of life, generally consciousness is a good thing, and we should not impair it, except for perhaps a grave reason.
Mm-hmm.
Consciousness is a good thing. Consciousness, God's given us to commune with him, to repent, really. That's why he's given us all of our lives, is to turn to him. But consciousness is a way that we can actually do that as we're approaching our death. And to play fast and loose with that and easily lighten consciousness, I think devalues that. So consciousness does have an intrinsic value in as much as it can be preserved. So there's a bit of a different moral calculus in practice between a Christian and a non-Christian, I would say, and exactly how we might dose things. The pharmacologic principles, we're going to be both operating within, acceptable standards of what is considered safe and effective, with, a knowledge or a sense of what the foreseeable side effects that particular doses are. I would say, perhaps this is the Ethan Schimmoeller opinion. I'll just say that. My own posture is to be on the more conservative side with dosing. Good physicians, I think, affirm that we want to use the least amount of medicine possible to keep you comfortable. I think we could amend that slightly to say but we also want to keep you conscious as much as possible. There is certainly a spectrum of practice where some physicians are more heavy-handed when it comes to using medications, especially those that impair the mind, impair consciousness. There's a little difference in practice between the United States and Europe. I'll point out on that front, Europe tends to be more heavy-handed. They're much more eager to do palliative sedation, for example, than what we are here.
Do you know why, or have any speculation as to why?
I won't claim to understand that.
Okay. I mean, this is the first that I even heard that. So it's not like I've dedicated any significant brain power or brain cells to thinking through that. But I do wonder, given that we have seen assisted suicide efforts advance so far in Europe, much farther than in the U.S., it makes me wonder if it is just due to a deteriorating respect for a culture of life, a deteriorating appreciation for the value of human consciousness and of human life. And maybe it's just, if you lose that appreciation, then you're just, let's just keep them comfy and stop them from complaining and give them the drugs they need to feel good.
That's, that would be my one speculation is it's kind of tied in with an anti-human philosophy that tries to blot out all suffering at all costs.
Now let's talk about the suffering piece there, because obviously, if you're a Christian palliative care doc, you have two patients in identical situations. You're the Christian palliative care doc. There's a secular, non-Christian, materialist palliative care doc. Both well-intended, obviously. So this is not casting aspersions, but you're going to be more conservative because you want to preserve consciousness, preserve that person's ability to commune with God, to pray, and also to interact with other people and preserve their relationships or maintain their relationships. And this guy is more interested in comfort. He's going to be more liberal with the dosing. That patient's going to have a lower level of consciousness because of that. I imagine your person will be in more pain, or at least more of the time, or in more cases, your person will be experiencing more pain. Maybe I'm incorrect on that. But even if that's the case, I mean, is there value to suffering? And if so, how do we understand that in the sort of Christian palliative care tradition?
Well, I'll just point out the kind of conservative approach I'm talking about with pharmacology, with medications, is within acceptable standards of how we use the medications. I'm not proposing that divert away from those standards in this.
What I have in mind is that basically
from standards of care, but this is not.
So basically, your colleague will do sedation, and you will cut a Flintstone vitamin in half, and you give that to your patient. That's what you're saying. I'm just kidding. Do you know the comedian Brian Regan?
Yeah.
He has this routine where he talks about like going to the hospital with like insane stomach pain, and he wants some medicine.
Hey.
Yeah, exactly. Say it's that one, and then he talks about like them cutting a Flintstone vitamin in half and just giving that to it. Okay, so but when you say more conservative, it doesn't necessarily mean the patient will be in greater discomfort. But could it mean that? And if so, how should we understand pain and suffering?
Yeah, well, I'll just say my clinical approach is not. I don't intend for people to be, in more pain or suffering.
Right. Yeah, makes sense.
I mean, we any of us go into this work to relieve suffering.
Yeah, for sure.
That's suffering is not a good thing in and of itself. But
okay, so maybe
our way.
Yeah, go ahead.
When it comes our way, I mean, the tradition is very clear. We ought to accept it. I mean, that's the cross.
Yeah,
that's the cross. Maximus, the Confessor in particular, has this beautiful theology about how God has given us death, and by extension, suffering, pain. He's given this as a gift to us, that Christ, through the cross, has actually changed the use of death, that we might use it as a weapon against sin. We might use it as a mode of purification. So that's a higher meaning for suffering, obviously, when it can be yoked to the theology of the cross and resurrection. Secular hospice and palliative care, in terms of meaning and suffering, it admits of some meaning, for sure. It's not no meaning. It's not the religious meaning that we have in mind, but it admits of some meaning. There's various respectable perspectives about the importance of performing life review, and perhaps listeners out there have had experiences yourselves where suffering has brought a family together, for instance. So there's lots of other modes of meaning that kind of cascade out of what we know to be the primary one.
Yeah, makes sense. Maybe a final question for you as we wrap up. With respect to end-of-life care and making difficult end-of-life decisions, I've puzzled through maybe one specific scenario, and I've talked to people who have a commitment to Christian metaphysics who go different ways on this, and I wonder if you have thoughts or could maybe recommend some ways to think about this. So let's say you have someone who has a terminal, I won't even say terminal illness, but some terminal condition. This could be a brain tumor that's advanced to a certain point where it's affecting the nervous system in such a way that certain organs can't do things on their own. So we might imagine in this scenario, a person whose brain tumor has advanced to such a point that they can't breathe on their own. So they're on a ventilator for assisted breathing. And they're on a ventilator, and they're on because they're on a ventilator, they can't be eating. And so they're on a feeding tube as well. And this person is not conscious, right? And there's not really a foreseeable path back to consciousness based on our knowledge of where the tumor is and all this. And then the tumor just spontaneously stops growing, goes into remission. So it's not advancing anymore. The other body's functions aren't shutting down. So there's not like a natural death that's happening. In this scenario, what does the doctor do? And the reason why I ask this is because, well, I mean, I guess I'm just curious about this type of situation. You can imagine like any number of iterations of this situation where we tweak one thing or the other. But this person's obviously on life support, and they're on, as you said earlier, this sort of like very technocratic life support. Like they're not breathing on their own, they're not eating on their own, they're not doing. If we had lived 50 years earlier or 100 years earlier, like this person would have passed away despite our best efforts to keep them alive, and yet we are keeping them alive, but honestly very artificially, and there's no consciousness, etc. So, is there a moral problem with? I hate the phrase pulling the plug because it sounds so mechanistic, but is there a problem with withdrawing that life support and allowing that person to die naturally? I think there's a pretty significant, ethical distinction between that and, helping someone kill themselves or killing someone. But yeah, I mean, talk me through that scenario. It's pretty complicated, and I imagine pretty darn rare to have something quite like that. But, what do you think about that?
Well, I would say that what I do in palliative care on a lot of days are variations on that theme.
Okay.
Actually, it is rare for each person in your life to experience it for someone close to you, but for those of us that are in healthcare, it happens every day.
Fair enough.
It happens all the time. That's healthcare that we've designed for ourselves at this point. So, at the level of the law, it is acceptable to refuse a medical treatment at any point.
Mm-hmm.
Okay, so that's the level of the law. Ever since at least 1976 and 1990, the Karen Ann Quinlan and the Nancy Cruzan cases, there has been a well-established right to refuse medical intervention, even if we know or have a strong expectation that will lead to death. So at the level of the law, anybody can refuse anything, essentially.
Okay.
That is not the bar for Christian ethics, of course.
Right, exactly.
It's a start.
Yeah.
Though, it's not nothing. It's not nothing. When it comes to Catholic medical ethics, I would, any listeners that want a much more clear reference on this that is brief and very accessible, look up the USCCB Ethical and Religious Directives for Healthcare.
Okay.
It's a comprehensive document, probably a dozen pages long, that covers the breadth of hot button ethical issues in medicine and what the church advises about it. I would highly recommend looking at that document if you want to hear this parsed out a little bit more systematically.
Mm-hmm.
Basically, for flowing out of the Thomistic tradition, the church, for at least the last several hundred years, has had this understanding of proportionate and disproportionate, or ordinary and extraordinary means of staying alive. The late medieval or early modern example, that's kind of funny to consider, but it's illuminating to think of how this terminology was crafted originally, was about, let's say, a doctor diagnoses you with an illness, and what they prescribe is a particular diet. But that diet is expensive for you who are a peasant. And if you were to try to pursue that diet, well, it would run you broke soon, but it would also run your family broke.
Right, yeah.
Are you obligated to do that? Go broke?
I would say no.
Exactly.
I would say no, yeah.
Exactly. There is more to life than staying alive.
Yes.
It's kind of the principle there. Right. There's more to life than life in the body. This life is a preparation for the next. So we are not obligated to pursue
life at all costs.
Life at all costs. To pursue disproportionate means, extraordinary means. Those two terms mean the same thing. Mm-hmm. Proportionate and disproportionate is a little bit more preferred nowadays. That calculus or distinction between the two, there's not a hard and fast rule in most cases to know where that distinction lies.
Makes sense, yeah.
It is usually in individual cases and requires the actual testimony of the patient, or at least their family, on what counts as a proportionate or a disproportionate.
So from the patient, could that be like an advance directive kind of thing that was prepared beforehand? Perhaps.
Or there's patients who are conscious and able to, speak or communicate about these things.
Yeah. Okay.
it would, for advanced directive wise, it's not unreasonable for someone to say, I would never want to be kept alive indefinitely on a ventilator. That would be a morally acceptable thing from Catholic medical ethics, because it's not hard to reason to see how that might be going about disproportionate means. The economic part, it's part of it, but it's not the whole piece, of course. That involves a heavy economic burden on the patient and family to be connected to technology for as long as whatever life you have after that is. You also have to foresee that the life that you're going to have is, and let me say this, I'm not trying to touch any of the phraseology about a life not worth living.
There, yeah.
One mentor of mine prefers the terminology, what is a treatment worth giving? To try to reframe it a bit. Life is always worth living. The tradition gives permission, though, to say that, to discern when God might be telling us that this life is coming to an end. There's other burdens that come with extending that treatment. Recurrent infections, for example, that require you to go back to the hospital constantly. Being bedbound, which in itself is extremely limiting and puts you at risk for any number of other complications. Not to mention, it's very difficult to have your family care for you if you're dependent on a ventilator long term.
Yeah.
Almost always you need to go to some sort of skilled nursing facility. Okay, so what the kind of future you're imagining, that is, many people would judge that is disproportionate and is, they would be certainly, justified in foregoing for continuing that medical technology. So we could probably do a whole conversation
for sure
off of this.
Yeah, definitely
on the whole theme of what does it look like to be pro-life at the end of life, because that's something we should probably just call out right here.
Yeah.
We've talked a lot about assisted suicide and about a kind of anti-human way of trying to blot out suffering at all costs that is certainly not consistent with the tradition. But being pro-life at the end of life does not look like extending life at all costs. It's not vitalism.
Yeah.
It's not eking out every second on the clock of our heart continuing to beat. That's not the purpose here. We're pro eternal life, you might say. We're pro spiritual life. We're pro being filled with the Holy Spirit life, so to speak. And so that
we're pro supernatural life.
We're pro supernatural life, you could say. So that I think some of the culture war paradigm is not very helpful when it comes to the end of life. And I do encounter this with families that share all or many of my commitments. And trying to work through this with them, it can be hard to kind of wade through some of this. Sometimes the culture wars really, I think, clouds their view and how they're trying to actually think through a situation the way that the church would encourage them to think through it.
Yeah, because I think you if you have the metaphysic largely intact but not entirely intact, you can think of death as the worst possible thing, right?
Yeah, or at the very least, have and this is not uncommon today, a deep and abiding suspicion of the physicians.
Yeah, that makes sense. You guys are all out to just, kill everyone. So, yeah, that's funny. I didn't even think about that, but that does make sense too. And then, there's probably a lot of sort of like, we know better than the docs and all that. That's tough. Your point about the care worth giving, it seems to me that, autonomy can be good to a point, right? When you have when you're talking with a patient, right? Do you want to be on a ventilator if that's the treatment that we have for you? And, do you want to be on a ventilator for, indefinitely at age 95 or whatever? Seems fair to sort of talk to them about their wishes there. But there's another instance in which that I imagine you'd still, as a doctor, be obligated to assist. Like you're going down the highway and someone gets into a crash right in front of you, and it looks like they hit the tree intentionally, and it turns out they did, and you run over to help out, and there's like there's a note on that says like DNR, right? Like, I don't want to be resuscitated, but like this person's their heart has stopped, and you're like, clearly I can do CPR. Like I know how to do this. They have a DNR, but like, am I going to respect this DNR for this, otherwise healthy looking, depressed 35-year-old? Like, no, I'm going to do CPR. You know what I mean? And so for that person who, maybe whose heart has stopped, like I think you'd even, from a Christian perspective, you'd be obligated to try to save them because it is not a disproportionate means to do that,
Yeah. And I would say for a young, healthy person, physicians should not be signing a DNR on their behalf. Even if the patient requests it, this does happen where young people who are depressed request not to be resuscitated.
Yeah.
There's even some weird circumstances that can arise where young people attempt suicide and end up in the hospital and then say that they don't want to be resuscitated when they're in the hospital, facing the consequences of how they tried to harm themselves.
That's crazy.
So you can imagine how that is that's a conflict.
Oh my goodness. Yeah. Big time.
Yeah. So, those, and don't quote me on what the law in each state says on these matters per se, but as a point of like clinical practice, physicians should not be signing a DNR for a young, healthy person, especially when they're influenced by.
I mean, I'm glad to hear that. I suspect that not every palliative care doctor shares, that opinion on that, but probably more palliative care doctors than other fields of medicine, right?
Well, there's more nuances than what I'm getting into here.
Sure.
But it perhaps might be worth just discussing briefly that resuscitation, CPR, is just not like the TV shows in the movie.
Yeah, fair.
It's just not. People have actually done studies comparing what do media portray as the success rate. Success being defined as getting out of the hospital and living independently.
Yeah.
Getting back home to something close to what you had before.
I mean, media, it's 98%, right? It's just like simple kind of.
It's like 60%.
You just like kickstart things going again. You're like right 60%. As rain.
I'll tell you, for me as a young person with no comorbid medical conditions, if I were to suffer an out of hospital cardiac arrest, my odds are much lower than 60% of getting back to what I had before.
Yeah.
And that multiplies the older and more chronically ill you get.
I mean, when I was
a patient with advanced cancer, their chances it dwindles down to under 5%.
Wow,
that's
crazy.
All that to say, we in America in particular have a very skewed understanding of what is involved in all this, and have a very messy cultural relationship with this procedure.
Well, yeah, I mean, because it's the go-to procedure in the movies. It makes for great TV. When I was young, I thought it was more like an AED, right? Which, when I think about that for more than 5 seconds, I realize how ridiculous that thought would be. But that, like you press on the heart until it can kind of jumpstart. And then it wasn't until I was a bit older when I realized, no, you're like compressing the heart to keep things pumping, which is crazy. I mean, that's certainly a wild substitute for the heart actually beating on its own. And then not to mention all the trauma that you're giving to the whole thoracic cavity. I mean, that's pretty tough on the body, I'd have to imagine. So
yeah, it is. Here, how I explain it to people is I say, if you die, do you want us to use heroic means to try to bring you back? Because the soul's not left the body yet, but your heart has stopped and you've stopped breathing. You're essentially dead. If you are at such a point of illness, very frequently you're beyond the reach of medicine.
Yeah.
And if medicine is successful in bringing you back, it's going to bring you back with numerous chronic conditions, including probably quite likely a severe brain injury, which is going to leave you,
severely incapacitated.
So that's all kind of packed within the resuscitation conversation and within the broader heading of what does it look like to be pro-life at the end of life. Just to say, resuscitation is not what it looks like in the movies.
Well, that's I don't really want to end on that downer of a note. So let's end up with something more positive. We talked about pro-life at the end of life. I think I'll use that to title this episode, because we are people of hope, Ethan. And although palliative care, based on everything you've told me, based on what I've seen in the movies, even though you burst that bubble for me, it's a messy, complicated, I imagine at times crushing and disappointing and heartbreaking and sad line of work to be in. But at the same time, I imagine you have chosen this because you have an awful lot of hope about palliative care and about being pro-life at the end of life. So let's end with a word of hope. What would you say? Well, yeah, I'll just give you that very open prompt. What would you say?
Yeah.
Word of hope.
Yeah. Well, let me just say this. In my clinical practice, it, at least in my better spiritual moments, is an experience of theophany. It is an experience of the manifestation, the revelation of God in the clinical encounter that I have with the patient. Not that I'm some holier art than thou, taking the gospel to somebody, although hopefully at least a little bit. I see it in patients. I recall an elderly woman I saw, won't give any specifics that would give away her identity. Happened to be a Sunday. I was not super happy to be working on a Sunday, especially on Sunday morning. I would have much rather been at liturgy, but I was there. And I realized when I left the room that I had my liturgical experience in that room with this woman. She had advanced cancer. It was gallbladder cancer, which can be kind of a really nasty, aggressive, painful cancer. And she was undergoing multiple procedures and surgeries planned. This elderly woman didn't give two hoots about how much pain she was in. What her mind was focused on was the spiritual welfare of her grandchildren.
Wow.
Her children had, they were part of some Protestant denomination. Her children had kind of wandered from practice. And so her biggest thing on her heart that was weighing her down while she is suffering from cancer in constant pain in the hospital is the spiritual welfare of her grandchildren and how they are going to achieve salvation when she's gone. She's thinking about her death.
That's amazing.
I was very moved by that. This woman has, amidst her suffering, thought nothing about herself. That is the mystery of the cross right there. And she had me grab a prayer book out of her bag. And we read Psalm 23 together.
Wow.
We prayed the Lord's Prayer together. And it was an experience of theophany. I hope it was for her. I know it was for me.
That's incredible. Yeah. That's a great note to end on. That's a great word of hope. Thank you so much, Ethan, for coming on to talk about all things palliative care and medicine. I learned a ton. Hopefully my listeners did as well. I think it's really important to be armed with good information from a palliative care doc who's on the front lines of this stuff so that we can understand fact from fiction in the right to die, death with dignity, assisted suicide debates, because these are coming here. I mean, they're already here in some states.
11 states.
What's that?
11 states.
11? Oh, I didn't know it was 11.
Half of the U.S. population lives in those jurisdictions.
Wow. Because it's, New York, California, right? Oregon. Wow. 11 states. That's crazy. So it's coming, it's coming soon to a body of legislature near you probably for debate and discussion. We should all be equipped to talk about these with our friends, make sure they know the ins and outs of what the actual on the ground reality is in palliative care, how we can do so much better for these people, so much better than helping them kill themselves. And we really need to be people of hope about this. So Ethan, thanks for sharing your story of hope at the end there. Thanks for sharing all these things. Really appreciate having you on. And thank you for the great work that you do for all of the people who are dying or on their journey to the end.
My pleasure. Thanks, Zach. Been a great conversation.
Great. Yeah, I really enjoyed it. Really had a lot of fun. To my listeners, if you have any questions for Ethan, feel free to send me a note and I'd be happy to pass on the questions. Or like I say with other guests, if we get enough questions, then maybe we can get Ethan to come back on and we'll just go through some listener questions on another show. So feel free to send me a note, zach@vernacularpodcast.com. We're recording this on the day after the Feast of the Theophany. So it's important it's appropriate that Ethan talked about Theophany. I'll be releasing this, like I said, after the Ohio State-Texas game. So we'll see how that one shakes out. But Ethan, thanks so much for joining. To my listeners, until next time, God bless you.